Hello, everyone. Thanks for joining in AOMA's guest speaker series. My name is Mary Faria, and I serve as the president and CEO of AOMA, Graduate School of Integrative Medicine. Today, it's my pleasure to introduce our guest speaker and our question and answer facilitator. AOMA is honored to have Dr. Damon Tweedy join us as our guest speaker for this Q&A session. Dr. Tweedy is a graduate of Duke University School of Medicine. He's an associate professor of psychiatry at Duke University School of Medicine and staff physician at the Durham Veteran Affairs Health System. He's published articles about race and medicine in the New York Times, the Washington Post, the Chicago Tribune, and the Raleigh News and Observer, as well as various medical journals. He lives outside Raleigh-Durham, North Carolina, with his family. He's also the author of a New York Times bestseller entitled Black Man in a White Coat, Doctor's Reflection on Racism and Medicine. Welcome, Dr. Tweedy. It's so good to meet you face to face, virtually, after all the email exchanges.
Exactly. Yes. Yeah, thank you for following up. I appreciate it. It's a pleasure.
I'd also like to introduce you to Latasha Tiffrey, one of our graduate students. She'll be conducting the question and answer session. Latasha is one of our amazing students. She's a naturopathic physician, continuing her studies to become an acupuncturist and herbalist. She's also the vice president of our student association. So thank you both so much for your time today.
Yes, pleasure to be here.
So we'll go ahead and get started. So we'll start with our first question for today, and that is, so in what areas of healthcare have you seen the most implicit bias, and when did this become the most obvious to you?
Yeah, so just thanks for being here. So, and I'd like this to be, if I may turn around, I'm a psychiatrist, so I may ask you questions as well. That's my work. That's the job I do. But as far as your first question, it's really, so when you're a medical student, you rotate through all the different specialties, certainly, pediatrics, psychiatry, surgery, and many others. And as you get into, even in my specialty training program, I started in general medicine. So again, you're seeing a lot of different things before I went to psychiatry. The truth of the matter is that it's in every field. I mean, there's really not any one field that I'd say dominates it. Any field where there are human, because medicine's a human interaction. So any field where there are humans, they're people, real patients interacting with real doctors, and other medical providers, there's going to be the potential for this. There are some, like for instance in psychiatry, there are system level things in certain fields that make it more likely to happen in other fields. But just from all fields no field is immune. Everyone's vulnerable to it. But like in psychiatry, for instance, the way our insurance system works, in terms of lacking parity, so a person might have general health insurance that covers general medical care, but mental health care, maybe the coverage isn't so good, and so that's where the disparities can really play out in terms of who gets care and who doesn't. But like I said, the bias itself occurs all across the board. And I saw it pretty early in the training. It didn't take too long to start to see how it could come across in so many different ways. The first couple of years into the field, you could just sort of see it. And it was striking. And I guess the reason I would say it's striking is because, at least to me, it was at the time, medicine and science, it sort of hold themselves out as being so objective and concrete and, above reproach, above the sort of stuff that the everyday person sort of, maybe is susceptible to. But, that's one of the dangers or traps that I think people can get into. The truth of the matter is that these fields are not above reproach. They're very much a reflection of what's going on in the outside world. And so the diffusion of bias can happen everywhere.
And I definitely agree with you on that. Being a naturopathic medical student, I saw it in every aspect of my training as well.
Yeah, tell me a little bit about that. So, like, what would you see? Like where would it come out? I'm just curious.
I graduated from National University of Natural Medicine in Portland, Oregon, which I'm sure you already know. Oregon is a predominantly majority white state.
Been out there once.
Oh, yes. And so I saw it pretty early on as well. I guess starting in my lecture with my lecture classes, just certain statements that professors would make. I just, one that stands out to me in particular, our gynecology professor made the comment that Black women were more prone to getting STIs as opposed to other races. And we had to talk to her about that. But still, throughout the training, even with during clinical rotations, certain, supervising attendings, physicians, you could see that they would favor the white students more so than the students of color, or we would get treated you would either get the silent treatment or you would get the harsh treatment.
Right.
So I
Right. So it's,
definitely did it.
yeah, so it's different, right? Exactly. So when I write about, in the book, and I've written about in other forms, there's two different layers, right? There's a layer of like what you might see happening to patients, right? If you're, you might see Black patients, underrepresented minority patients experiencing, but then there's also what you yourself might experience as a student or a provider, and then trying to navigate that as as someone who sort of doesn't fit in, right? So there's kind of these two different layers to see. I've written and talked a lot about both. Just to kind of go back to your first point about the classroom setting. Yeah, I mean, what's interesting for me, my experience was as a first year student, you get these lectures and there's this conception about like this disease is more common among Black people, or this happens, Black people are more susceptible to this or that, but without any kind of context. It was just like there's like these labels kind of slapped on you. There's no context to it. It's not framed in any sort of way in terms of society, in terms of history. It's just this is what it is. And I think what happens a lot of times that people sort of like start to, it's almost as if there's like this genetic biological thing that some people attract, some people think about, and other people I think is this track where they think, well, Black people just, or other, not just Black people, but I'm referring to Black people here primarily, but just don't do the wrong thing, and that's why they have bad health outcomes. So it's like these two different tracks, and there's a lot of bias here, right? Because there's really very little context, if at all. So yeah, I mean, you see it in the classroom, you see it when you see patients, but you also experience yourself as a student or as a trainee, and so you kind of get it from all directions, and that's a lot of what I've written about, what I wrote about in my book, and what I've written about in other forms. You see it in so many different ways.
Exactly. Makes it hard to advocate for your patients of color when you yourself are dealing with it as well.
Yeah, and the challenge also, another challenge is that if you're the student, like historically, right? So I mean, like I'm curious what's like in your field. So like in the medical school world, you know, about 6 or 7% of students are Black. The medical students are African American or Black. Um, it varies across country. But when you're talking about as you get further up the ladder, like the professors who are teaching you, it's about 3% of professors at the assistant level, which is like sort of entry level, or African American. And then you get to the social level where I'm at, it's about like 2%, and then the full professor level is like 1%. So you can see how the students are much less likely to encounter a professor who looks like you. And then there's the idea of the professor's the one that has the knowledge, they have the experience. And so even if you kind of question them, sometimes your questions can kind of get lost because you're like, well, you don't, because you don't know the medicine as well as they do at that point in your training. And so you're like, well, maybe is this bias or is it not? And then you also just the hierarchy of it, right? You're in a total. These are the same people who are evaluating you. So if you
Right.
call them out,
Right.
what's going to happen to you? And then if there's a patient who says something to you that seems amiss, is that person going to be able to support you, understand you, support you? There's a lot of different challenges that are out there.
I definitely agree.
Yeah, what are the percentages like in your field? What is it like?
We will take your field and just say less.
Okay,
A lot less.
not surprising, and that's true for. I think that's interesting because a lot of allied other health fields. It's very true. Like the psychologists I work with, it's like 1 or 2% of Black psychologists or marriage family therapists. I mean, so yeah, it really gets less and less, and so yeah, I think that's very true.
Even with Chinese medicine, it's majority white students.
Yeah.
There aren't even that many Chinese students, which is like shocking.
Yes, exactly.
Um, okay, so we'll move on to question number 2 now.
Okay.
What do you believe are some of the ways we can make integrative medicine more accessible universally, and how can we bridge the gap between traditional and integrative medicine healthcare a little bit better?
Yeah, I'd love to hear your side because we've come at different educational, different tracks in some ways. Um, Yes, I think I mean, so like if I'm going back to when I was a student, it basically was like completely off the margins. It wasn't even like, it was not even really in a conversation. It was almost like, well, I've got the terms. There was there's a lot of disparagement, right? There was this sense that, again, there's this evidence-based medicine, this scientific medicine, and this is really the only way to do things, right? And if you don't fall within those parameters, then, we can't really help you, or it's just all in your head, or there's just all these sorts of things that people would sort of, there's a certain dismissiveness that was been around for a long time. I know at my school, about at Duke, in the last 15 years or so, this integrative medicine became part of the a little bit more of the integrated to the, for lack of a better word, into the medical school. But even then, it's still kind of, there's a clinic, we have an integrated medicine clinic, but it's kind of far away off campus, and you could go through your whole 4 years education and never encounter it, unless you have the actual interest yourself to sort of seek it out. So right now, there's more, the opportunities are there, but you have to sort of seek them out. It's still not like part of the regular curriculum, which I think it should be, honestly. I think there's so many ways in which it should be, melded into the general curriculum. And I don't think it even should be something, even when you do that, one of the dangers is that if you make it like a separate class, like, oh, this is the day we have a lecture on medicine, that still kind of marginalizes it. So it's like, how do you incorporate it in all facets? Like, if you're talking about pain management, that should definitely be part of the discussion, right? That shouldn't just be like an afterthought, right? Or it may be like maybe that should be the first thing you should think about before we go to some of the other treatments, right? Same is true for all other sorts of health related issues, whether it's managing, blood pressure, diabetes. How are we doing that piece? So I think these things have. So I think it has to happen in a more mandatory way, but I think it also has to happen in a more, like, again, for lack of a better word, an integrated way where it's not a separate course or a separate location, but it's built within the fabric of the institution itself in terms of how they teach certain subjects. I got to tell you, like you mentioned, I think it's acupuncture, right? And so I remember learning something. There's been I was out of practice, and a patient had been referred for back pain, which you think about, which is what I would think about. An average person would think about when thinking about acupuncture. And then he was describing the benefits to his mood, and I was like, like what's I was just wondering, like, is that just placebo kind of? I was like, what is that? What's it to? And I started looking up, and I had a second patient say the same thing. Then I started looking it up, and I'm like, wow, I never would have known that, right? And it's just like it's never even built into your educational training, that there are these other alternatives that could be really helpful for some people. And so I think it's just right. So I think it's just the school's got to make that. You got to have people who are. There's got to be a better way to teach it from an earlier period. So I think you got to get faculty who are. But I think the problem with medicine is this. I mean, this is just. I mean, I want to hear your thoughts, 'cause I don't want to just keep talking about it. But I don't hear your thoughts. I think the problem with medicine is that you need, like, if you have someone who's never been trained in that mode, they may even see it as a threat in some way. Because especially if they don't understand it that well. So I
Yes.
think that's where the lack of knowledge comes in, and if it's perceived as a threat. And so you have to get people. So I think that there are some people I know in medicine who are kind of like bridges. Like they've trained in the traditional way, so they know all that stuff, but then they also know this other way. And I think the more we can have people like that doing the instruction, and having a greater role, more prominent, the more we can just more do some of this. So what I've done in one of my roles as an instructor is I have a couple courses, a behavioral health course that I teach at the med school, and I've been trying to find ways to actively integrate this into our training. So I've taken the students to that integrated medicine clinic. I've had people come and give lectures and describe patient scenarios and things of that sort. So it's been really helpful to at least get students exposed to it. But I think it needs to be more of that, But tell me your side of it. Like, what do you see from when you see what you hear about, my world, and what kind of resistance do you butt up against?
So I agree with you on the ways in terms of bridging the gap between traditional and integrative healthcare. Education is the key, and it does need to start early, which is one of the reasons why I joined the SMA to begin with about 4 years ago almost. Wow.
Yeah.
So I'm one of the few, if any, integrative health students within the
Yeah.
SMA. I'm trying to get more students on board as I learn about and navigate the organization myself. And with that, like I said, we have ties at AOMA and Dell Medical School. We've now
Yeah.
like joined together
That's great.
with their integrative health interest group. One of their
Okay.
students messaged us a few months ago to see if we
That's
can
great.
start coming together to do some East meets West case studies.
Yeah, that's great. Yeah,
Um,
that's awesome.
so we're going to start doing that soon. And we're also doing a series throughout the school year entitled "What is Integrative Medicine?"
Yes.
And we're kicking that off tonight with our first panel discussion, which I'll email you about a little
Yeah.
bit later. Um,
Yeah.
We'll continue those panel discussions throughout the year, as well as our case studies, and everything's going to be on Zoom, obviously, because of COVID.
Sure.
So education, I said, is the key. So we've invited all of the SNMA. I believe there's a Latino Medical Association. We've
Yeah,
also,
exactly. Yes, I know that one as well.
so
Yeah.
for all of the schools in Texas, medical schools, and as we move further on, we'll invite more schools throughout the U.S. To see how many end up coming, which will be awesome, as well as the UT Pharmacy School and some other organizations
Yeah.
and individuals as well. And we're with these panel discussions, we're going to invite just different, like you were saying, healthcare professionals in the field, MDs who are already like practicing or who've been practicing in integrative medicine. We're going to discuss the ways with them that they have gone about practicing it as well, so that I guess future MDs can kind of have an idea of what it is, not only what it is, but how to go about practicing it.
Yeah.
Also, another thing that I know I still need to talk to Mary about, I've been meaning to talk to her about, is the Dell Medical students. Well, their focus at Dell Medical School is, well, one of their focuses is serving the underserved, which is awesome. Another focus is integrative health, which is, I think, one of the reasons why they've joined up with us. The Dell Medical students, they actually get a year off. They have a very intense program. Like, they go hard first and second year, like more so than other medical schools, and they don't have any breaks. But then come third year, you get like a full third year off to go off and do whatever you want, get an MBA or
Yeah, it's just like
whatever.
Duke.
Right.
Yeah, Duke has the exact same program.
So I'm wanting to maybe see if we can form some kind of program at AOMA, like a year-long, like intensive program for them to come and do maybe some Chinese,
Yeah, that'd be great.
acupuncture, herbal studies, and get something out of that, to where they can practice that once they go into their practice. So that's another way. I know more MD schools have gone towards doing that, like letting their students branch off and go and get other degrees.
Yeah.
So that's another way to kind of weave integrative medicine in.
Yeah, because historically now, I mean, historically what's happened, you look in the field, a lot of folks who got to integrative medicine, they sort of just kind of happened into it, like they were starting to practice regular traditional medicine. They found that there was something missing. The patients they'd see, people would, they kind of go in this kind of treadmill, and they wouldn't sort of it wouldn't work for them, right? And so they started, and maybe the patients started to try other things, and then that's how they learned more about themselves. And a lot of times, a lot of physicians they have integrative medicine fellowships that some traditional programs can do. There's the one in Arizona, which is probably the most famous one, but there's other places where we can do integrative medicine sort of fellowships after your training. But a lot of times, it's not starting at an earlier phase. Another point I think you mentioned, which I think is really important. Am I still there? Am I?
Yes.
Yeah, I thought you froze on me.
Oh, sorry.
No. Another thing, you can sit still really well. Is that part of your training? How you
I know, it's weird. Like
wow, I was impressed. It's like, wow, she went still on me. No, but another really important piece is the interdisciplinary training. So like the idea of like not medical students not only working with other medical students but like working with pharmacy students and physical therapy students, as you mentioned. So I think the more we can sort of have training models that do that, you can get exposed to it at an earlier place as well. I mean, that's one of the things I really wish. In my field now, I work a lot with different disciplines, but it really would have been great to have done that, coming up along the way. I think there's a lot more I probably could have learned at an age when I probably could have retained more information, if I'd had those kind of cross-disciplinary experiences. I think another we may get to this later, but I think another really important piece about the integrative medicine barrier, you mentioned about your involvement with the SNMA, with the Latinos Students Organization. I think there's a perception, I certainly had it, that integrated medicine is something that is for people who are well off, who have free time, free money, disposable income, not for just everyday regular people, right? And so I think there's very much the perception that this is something that's an add-on for people who have the luxury to, like, it's almost like private school, right? It's almost like it's like that sort of concept. So I think that's a real barrier. But there's so much wrong with the traditional medical curriculum. Like, can you tell me how much? I'm curious to know, like, what is your education like in terms of like learning about nutrition and food and plants and herbals and stuff? Ours is basically non-existent.
Wow.
Yeah. I mean, can you imagine you're a medical school physician and you get like 1 hour of a lecture on nutrition? And like, I mean, it's like, that's insane. And so you don't even know how to talk to patients about diet. So what's yours like?
In the naturopathic medical curriculum, I feel like we got like three quarters, at least 3/4, like a year's worth of nutrition.
Yeah.
In addition to like all of the ologies, pathology, what else? Cardiology, all of the ologies. We still had to do our natural medicine therapy classes as well. So, but in addition to nutrition, it's huge within our curriculum. In AOMA, we also have a nutrition class, a pretty intensive nutrition class, where it's like half and half conventional medicine nutrition, and then half Chinese medicine nutrition. And it's a pretty intense class.
So I'd want to know what Dell's nutrition, maybe they're more so because they more focused on integrated medicine, but I'd be curious to know what their nutritional education is like. I think that's one of the biggest shortfalls of traditional medical education.
I agree. I honestly don't know what their nutrition, but that would be something good to find out.
Yes.
Wow,
Food is medicine, right?
it really is. Okay, so moving along. In your career, you've been exposed to a lot of racism. So, what do you think it will take to truly change or eliminate racism in the medical schools and in those that provide care? Do you think that is even possible?
Yeah. What do you think about? So, what do you think about it? So, like, 2020 has been this race conversation has really taken some a lot of steam, right? In 2020. I mean, what do you? I'm curious to know your feelings about some of this as well. I mean, so my take is that the combination of COVID-19 and then everything that sort of happened with where everyone was sort of slowed down with the pandemic, in almost isolation almost, and then all those things happened got amplified. The videos of different people, it seems like they got amplified, and combined with the way with the shutdowns, it sort of amplified the messages that came from those. Because those videos, yes, they were powerful. They weren't new. I mean, it's not as if it's the first time that someone's been, we witnessed someone being killed in in that sort of way. Um, Yet it took on this different level of urgency, I guess you'd say. Um, so that's led to a lot of medical schools and other sorts of society trying to take a close look at their own practices, right? And what can they do to sort of, what are we doing wrong? How do we get to this road? How do we get out of it? Um, I don't think, to answer your question, like, can racism be eliminated? No, I don't think it can be. Do you think so?
Not in our lifetime.
Exactly.
And
Yeah,
then,
not exactly.
unfortunately, this
Yeah.
whole presidential race has already shown us that our country is divided
Mhm.
like 50-50 in half. So, like,
Yeah.
not in this lifetime. It's going
No.
to take really long because it's not just within the U.S. It's an international.
Exactly. It's a worldwide phenomenon.
Right.
Exactly.
So,
Yeah.
I do like the fact that people are now more prone to listen to us when it comes to issues of race, with everything that's happened this past summer with all the protests and all the, like you said, like things that have been filmed, with different people being murdered and, by police officers. I think that's going to bring up, and already has brought up, an interesting question of reparations for Black people in this country. And I know one of those reparations includes healthcare. Um, as one of the aspects of reparations. So, this definitely plays into that. So, once they start, like, I guess, sussing all of that, everything out with reparations, especially the healthcare aspect of it, they're going to have to include racism within the medical system within the United States.
Yeah, so I think one thing this has allowed is to allow people to sort of to go back, um, and take a look at how we've gotten here, right? So I think because again, a lot of times in these lectures, students are just taught this is how things are, and it's just like there's not, and it's like, and there's still people obviously who feel this way, but that the problems with race are things that happened a long, long time ago, right? And why are we still talking about this now? You see, that's what some critics would say. You hear that all the time, but I mean, so I've been doing this project at Duke where we've been going back and sort of department by department, and we've been going through each department and so looking at their history and kind of what's it been like in terms of their patient care and the segregation patterns that were happening in terms of who got care and who didn't get care, and just some of the as you said, some of the racism within these different fields. And we've been kind of going back, and it's just like, wow, it's striking. We're talking 20, 30, 40 years ago. It's not as if we're talking 200 years ago, right? And so so these things have very much powerful impacts on the people that are still there now. So I think the original question was, what do we do about medical racism? So just to go back to again, how'd you frame it?
Um, what do you think it will truly take to
Will
change,
take. Okay.
to truly change and eliminate racism in the
Yeah.
medical schools and
Yeah.
in provide care? And do you think that's
Yeah. Yeah. So a couple things. All right. So obviously, as I mentioned earlier, what's happening in society. So nothing. Medicine can't. The society has to advance for medicine to advance, right? So because what's happening, because the people who are doctors are just people who are products of society, right? So so the more we can address these issues in a more society wide standpoint in terms of conversations about race and also actions, right? And so this has to happen much earlier and much more integrated throughout society, because I guess I would say when we talk about these messages about race and racism, they start early. You get them early. It's not as if you just wake up one day at 22 years old and you got this.
Right.
This is happening from much early age. We have to think about the messages that we send in the media. Like what is the media? What kind of images are they putting out there? Like when you see the images of Black men, in space, like and Black women. Like, what are those images? And sometimes I'm always struck by this idea. People say the media has got this overwhelmingly like progressive bias, but I see it maybe differently. I see it as there's a lot of harm that they do in terms of some of their deliberate portrayals, negative portrayals, and what does that do, right? And so, but as far as what medicine has to do, medicine has to sort of first acknowledge that, again, we are not above the fray, right? That we are products of this world, and so and we are, and the bias is there in all of us. I think we have to sort of acknowledge that first of all. I like to think of it this way. So when I tell, like we talk about in doctor-patient situation. So if I'm seeing a patient, and so you have to understand that patient is coming into the room, and they have this bag, a knapsack or bag, and in that bag they're carrying their history. So it's not just a isolated person; they're carrying their own personal story, but they're carrying their family's experiences with the healthcare system. They may be carrying community experience. Maybe they've read or heard about a certain study. You know, everyone knows about Tuskegee or whatever. They're carrying a community experiences, but they're carrying their personal experience and their family experience. And so a lot of times, what I'll see is that a patient may be really mistrustful of the healthcare system, and for good reason. If you go back and look at some of the stuff, like, I mean, maybe we can talk a little about this, but I mean, if you go back like 50s, 60s, 70s, there was outrageous stuff going on. Like, I was born in mid 70s, and up and through there was so that Tuskegee thing went through the early 70s. There was a prison experiment that was taking place called the Holmesburg Prison Experiment. It took place in Philadelphia, outside Philadelphia. The guy who's now he's dead now, but he was famous for creating the treatment for Retin-A, you know, the acne treatment. But they were doing experiments on prisoners, putting these patches on prisoners for years. A book called Acres of Skin. It covers this whole history. They were doing all this really outrageous stuff. They were like experimenting with like toxins on people just to see what would happen to them if you put this on someone's skin. There was, in North Carolina, throughout the country, there were these sterilization programs that were taking place,
Yes.
where women were being sterilized. This happened into the 1970s. You know, again, we're not talking about 1870s, right?
In
So
Puerto Rico.
yeah, exactly. Puerto Rico, yeah, it's talking in 19, and it's a whole list of these things. These are happening. You know, this is like 30, 40 years ago. I mean, we're not talking like 150 years ago. So it's like, we have to understand that these mistrusts and then beyond that, there's individual stories, even more so than those kind of outrageous things. There's actually so many cases of individual people who've come to doctors and been dismissed or been demeaned or not taken seriously. And then that story spreads to their family, to their community. And so there's a lot of mistrust that we have to sort of account for and address, and not sort of point the finger and say, what's wrong with you? And say this person's not compliant. That's the thing that we use in medicine a lot.
Right.
But like, what's that story? What's that history? And then it's also like, what is your history? Like, what are you bringing into the room when you see that person? What is your story with waste? What have you learned? What have you sort of assumed about people that maybe is not so true? And so the more you can sort of have humility, right, and understand yourself, but also understand the communities that you serve. Like, until we do that, like, you can't just come into a community as a doctor, not know anything about the community, and think that you have all the medical knowledge and that you're going to be helpful to people if you can't understand the people in their community and the context in which they're living. And so I think medicine's got to get there. So, I mean, you're talking about how do we get out racism, we got to have that level of humility and understanding and inquisitiveness, and willingness to reckon with what's happened in the past, because there's a lot of reckoning that still has to happen.
And I agree. Eugenics has pretty much taken its toll on people of color, communities of color, in the country and internationally as well. And it has caused a lot of mistrust within the healthcare field. I guess more recently, with the COVID vaccine, we're a little skeptical about that. I'll be honest. I'm skeptical. I don't trust it because of all the terrible things that this country, as well as other countries, have done to people of color in terms of medical experimentation.
Right. Yeah. I mean, so there's a book called "The Medical Apartheid." It's by Harry Washington. It's got a lot of traction because it goes into that experimentation theme. You know, there's this term called I mean, it's really sad. It's called Mississippi appendectomy. It's this idea, the idea of a woman.
Fannie Lou Hamer?
Yeah, Fannie Lou Hamer in Mississippi. Yeah, civil rights activist in sort of in the mid '60s. This idea of like you go to a doctor for an appendectomy and you come out with a hysterectomy, right? So, it's just really horrible kinds of history, right? And so that has to be dealt with. And so so let's bring it to the present. COVID vaccine, right? We get a couple reports earlier this week about how effective they were. You know, there's Pfizer and Moderna. But one of the things earlier I heard about was that they were having a hard time recruiting Black people into the studies, and of course,
they were trying to experiment on people in Africa. Did you hear about France?
No, I mean, but it doesn't, it doesn't
France
surprise
made it
me.
known that they wanted to start with Africans
Mhm.
who, might I add, Africa has not experienced nearly the amount of deaths
Exactly.
that the rest of the world has experienced
Right.
with COVID. Like they're not even close to what everyone else is
Right.
experiencing. So I don't even understand why they were trying to start in Africa. Well, I do understand
Yeah.
why they were
It's
trying
the
to start
same
in
way
Africa.
you experiment with the prisoners, you experiment with,
Right.
but so
Similar with black people.
yeah, what's a larger theme though of like the idea of the body being sort of like a second, the black body being sort of disposable in a certain way, or like being as a tool to learn for the larger population. It's been that way for a long, for centuries, and so we have to grapple with that when we think about disseminate, because I think the COVID vaccine, I think it's going to be important, right? I understand your concerns, but at the same, absolutely understand your concerns historically, but at the same time, it's going to be important. If we, it's going to, there's certain people, because the data does show black people have been in this country because of our healthcare system and our society, the way it works, being much more vulnerable, right, to COVID-19 ultimately. So but it's a delicate thing, right? And so and if we don't grapple with that history and understand it, we won't know why this person doesn't want the vaccine, right? And we won't know why if we don't understand that history.
Right.
Yeah. So,
Exactly.
yeah, exactly. So I think it's extremely important.
Okay. So moving along, um, what one piece of advice would you give to those entering healthcare provider roles that will make a difference when they serve people of color?
Yeah, I think I mentioned it previously. This idea of like you remembering like this sort of metaphorical bag that the person brings to the room. Because what happens a lot of times is a patient comes in and they're like, "This doctor says you need to do X, Y, Z," and they're like, "I don't know about that, whatever." And then the doctor gets defensive, and then they say that what's wrong with the patient. Or they take it personal, like the patient is saying something to them directly, and they take it personal, and then this labels start happening. This person is non-compliant with their treatment plan, and they're a bad patient, kind of stuff. And I think a lot of it is not having the humility to recognize that maybe it's not about you per se. Maybe it's really about this patient's understanding of the system and their experiences with it. And maybe also recognize that when someone sees you, they might see you as representing that system. And you have to have the humility to not take that personal, but to understand how you can work through that, right? It's not just about always just about you. It's about these larger things as well. And so I think the more you can kind of do that, and have curiosity about the people you see, you need to understand their history, but you also need to understand this is a person. You got to try and connect with the person as an individual person as well. The more you can do those two things, the more you can sort of, mitigate these problems with that we so often see. So I think that's probably the advice I would say in order to sort of provide the best kind of care to those communities.
I would agree. In terms of humility, I feel like a lot of the times our, I guess, white healthcare providers, they come to us with this God complex, like
Yes.
you should worship me, do everything I say. And they don't listen to what the patient has to say, and then, like you said, you get labeled.
Hmm.
So
Absolutely.
this
Oh
idea
gosh.
that they are right and you know nothing, so you just listen to everything they say, and that
Right.
that creates a huge barrier between the patient and
Yeah.
the doctor when
No,
when
absolutely.
when there's the lack of humility with the doctor.
Yeah, and it's also a sense of inflexibility. Like this is the only way to do something. Like I think that's another problem you have to realize. There's a lot of ways. Most medical conditions, most ailments. There's probably a lot of different approaches that we can do, and we need to sort of make it something. See what the person wants to do, what they'll buy into. I think it has to be a collaboration. It can't necessarily just be you need to do X, Y, Z. I think that's just often. I mean, there's some life-threatening examples that the exceptions, but in general, I don't think that's the way to approach seeing patients. And I think that's one thing we do a lot in medicine. Another thing you just kind of alluded to, I think is really important, our documentation system. So I'd want a young person to learn that how important that role is. Like what you're putting in records is so important. So when I give formal talks, I talk about this. There's studies that look at this. Like you describe a person in a certain way, and then that gets put in their chart. You get a certain label, you get a certain description of them, and then the next person sees that they draw on that information, and the next person, before you know it, you've sort of been labeled, right, in a
Right.
sort of way, and then it's like you can't get out of that, and so this happens a lot. I mean, it's unfortunate, and so I think it's really important to, again, I go back to the word humility, right, but it's also really to realize there's a tremendous power, because if someone comes to me, they're expressing their symptoms, their story, and then I'm putting that on in paper. I'm the one that's sort of the author of that, right? And it's a real something you have to really take seriously. I can't tell you, like in my field of psychiatry, how many times I've seen patients with, it's often, all too often, the black patients, they're labeled. There's certain labels that kind of come up. Schizophrenia is a very significant, serious medical condition, but also too often you'll see people get that label too easily, particularly if they're black. You'll see people. There's this condition for children. It's called oppositional defiant disorder. It almost even sounds like something that's like a label, right? And you
Yep.
can just and you can see certain Black people get that all the time because they're not following the whatever is supposed to be the and so these kind of things can be troubling, and they get put in a chart, and then the next person sees them, and then they automatically assume. First of all, if you see a psychiatric label on a chart, there are one challenge is that they may be less likely to take your physical symptoms seriously, and that's a very real. So you got to be really careful about what you're putting in people's charts, and it needs to be real care taken to that. I mean, there's so many challenges that that have to sort of be addressed in that way.
Right. I actually wrote
So I was,
I wrote a case paper about oppositional defiance disorder when I was a medical student, which is pretty interesting. Now that you've mentioned that, I can see how Black patients and patients of color in
yes,
general can easily get those labels. Wow.
absolutely. I mean, it happens a lot, and it's unfortunate.
Wow. Okay. So for our final question, what one piece of advice would you give to those of color who are future medical providers who will likely face racism as they progress through their career?
Yeah, I think before I get to that specific piece, I wanted to give some advice to people who are supervising them, like the faculty. Let's say the faculty who is not, let's say it's a white faculty member supervising a student of color. Um, I think one thing that's really important there is there's two things. One is that a student of color enters into a space which is primarily going to be, in most cases in medicine, is going to be mostly white.
Right.
As you say, with the recent election, right? You can see how the country split. So when you go into a room with a group of white people, you really don't know where they're coming from. You don't know at all. Like you see this and you have no idea, honestly. And honestly, a lot of times there's a lot of energy wasted or spent trying to navigate that. Like trying to think is how is this person perceiving me? Am I going to be X, Y, Z? Are they going to give me a fair shake? There's a lot of that kind of energy that students spend. So if you're someone who is inclined to support students of color, I think the more you announce that and just upfront about that from the outset, I think you can alleviate a lot of student distress because a lot of, I mean, up from the out, just sort of be intentional about that. For instance, some faculty I know will make it a point to always recruit minority students to their lab to do research with them. So they're intentional in terms of their efforts to support minority students. 'Cause I think, like you said, that last lecture just shows, right, there's a tremendous divide, right? And you don't know what you're getting into when you walk into that room. You have no idea. You have no idea. And so I think being intentional about that, but also if you're that faculty member, being willing to support that student and know that their experience might be different, right? Yes, they want to be treated like every other student, mostly, but there can be experiences that could be different, and you might need to be attuned to those. Like if they go into a room and this happens, and they see and a patient says that they don't want to see a student who's a woman or who's Black or whomever. Now, what do you do if you're the faculty member there? Do you just kind of ignore that? This is what I've seen. So, like I saw recently, it was a case earlier this year. It was a student who was had a Mexican heritage, and another student was Asian heritage, and the patient was white, and the patient said he didn't want to see either one of them, and basically used some slurs to indicate why he didn't want to see him. And then the faculty person who's white kind of goes back, and they go back to the faculty person, and he says, "Oh, don't worry about it. I'll just see the person. Like, don't worry about it." But see, what he probably should have done was sat down, said, "Man, I'm sorry this happened. Can we tell me how you're feeling? What do you think we could do?" To give the students some sense of like, agency and input versus being dismissive, right? Because the student it was kind of brushed aside. And I've had several Black students say similar kinds of experiences. And there's some cases where, maybe the faculty member shouldn't intervene. If a patient is really being hostile to a student, maybe it's not just okay to just let this patient say bad things. And I think historically in medicine, these things have happened. And so I think, so I say for someone who's white, you're supervising minority students, you need to sort of be attuned to those kind of issues. Be intentional in your support, and also, be mindful that they may have additional challenges, right? And so I would say that. You going to say something though?
And aren't we allowed to refer patients to other practitioners? Let them know, that these students have every right to practice, and if you don't feel that you want to be with them, then you can go elsewhere.
Yes, exactly. No, that's part of what I'm saying. That's my point. Exactly. That's part of like what you may call a patient or student bill of rights, right?
Right.
I'm not provider bill of rights. Like maybe they have the right not to be, these sort of things. Exactly. So maybe if that's your choice, then you should probably go elsewhere, right? I mean, no, I agree. And so that's the kind of statements that some programs are starting to make, but that's been a long time coming. So I agree absolutely with you. Yeah. So you're starting to see that happening now. As far as advice to the students themselves, I would say that it's really important to just have support, to realize that there are other people out there who are having the same experience. And I think the more you go into it feeling isolated, and that you're the only one experiencing it, the harder it's going to be for you. Making those connections, whether it's the SNMA as you described, or other resources, but also reaching out to junior faculty, train people further along the program than you who've gone through some of these same experiences is really important. Because the more you can more you can sort of draw on those different experiences, the more the support you can have, the more you can realize that it's a larger struggle. It's not just your own individual struggle. I think those things can really help you. Again, if you have white faculty who could be supportive and be intentional in their support, they also could be resources as well. You shouldn't just restrict yourself to just only seeking, support from people who are your own race, because man, if you do that, it's going to be hard because there aren't many of us around, unfortunately. So you got to branch out a little bit. So yeah, so I think all those things are really important as far as advice, but also just recognizing that because because of the history and where our country's been. You can do a great good for a lot of people. There's just a lot of really great good that you can do. There's so many people I've seen over the years who said that, seeing me felt like it was a lifesaver, like they'd given up on the traditional medical system, whether it was, taking, insulin or just anything that was sort of standard, treatments for depression. They'd given up on a lot of different parts of the medical system, and having me help, my presence there was sort of almost like I use the word sometimes like a translator, a medical translator. Like I could help sort of bridge the gap between how the traditional medical system maybe failed them, but how it still could help them. And so I think sometimes you can be a really as an underrepresented minority practitioner, or as a woman. In many cases, you see women providers can do wonderful things with patients. So these are the kinds of things where it's really important. And so I think there's a great good that you can serve, but just know that there's people out there who will support you, who've been through it, and want you to succeed. I think the more you can have those in your mind, the more you can sort of have a better chance of succeeding. Yeah.
Well, thank you so much for your time. Hopefully we can have you back at some point in the future for more discussion.
Yeah, I mean, we scratch the surface of a lot of different things. I ramble a lot when I get on these subjects. There's just so much interesting stuff you can talk about. There's so many different things we could have gone into more detail about. But yeah, I think we're on the right track. The more we can integrate our fields, the better we all will be, for that. So I think that's probably the larger message. And then also just the more we can make this feel like this is something that's for, again, I can't stress it. I feel like the integrative medicines often feel like it's not for underserved communities. And the more we can make it feel different, and more we can take action to make that better, the more we can advocate for that. We can advocate for, insurers and things to sort of to participate in that. The more we can do that, the more we can really make this be what it needs to be, and not just as something a side thing, but really very integral, better word. So the more we can do that, the better.
I completely agree. Thanks.
I want to thank you both. It's been wonderful. And Dr. Tweedy, I hope you will join us again.
Yeah, no, I'd love to. And I'd love to, will there be a link for that?
Yes,
for that program?
I will send it to you right after the meeting, after our discussion.
And will that be recorded though? So, because I don't know, I may have something later, so I can watch it later if I have to.
It will.
No, it's going to be recorded.
Oh,
it is recorded.
Yes, that's great. Yeah, I'd love to do that. So yeah, so stay in touch. Hope wish you guys the best.
Thank you. You as